testable for respiratory distress, just this first lecture. We're going to cover this one in asthma today. But this one is really just background information on some of the how respiratory distress will present, and just some of the common, differentials, testing we can do, ancillary testing associated with it. I know you guys are all wondering, like, the only thing you really care about, you're like, screw this, what's going on with surgery on Friday? I know. I'll look it over tonight, and then we'll talk about it at the end of my lecture tomorrow. So I rarely go for 2 hours. If I do, something bad happened or something went wrong. I don't know. computer died, something. But yeah, usually I talk a little bit faster. If you have any questions, please stop me and ask or clarify anything. If I say something completely wrong, you should probably correct me. Although you guys never do, and then later I'm like, man, I completely said the wrong thing. Oops. All right, well, we're going to move into respiratory distress. There's Tinolli's. I'm sure you guys have never opened it, but we're looking on the computer. You could kill somebody with the book. It's like 12 inches thick. But that's what we're teaching out of. And then here's our objective. So we're going to define some things. We're going to talk, discuss pathophysiology. We'll talk about our evaluation and what we typically do for the presentation and how we're evaluating these patients. Now we won't cover a lot of treatment options. We'll cover some background on important ones like non-invasive positive pressure ventilation, which is a common modality we use in the emergency department for these patients. So everything in the ED, we like to establish our safety net first. So what is that? IV, O2, monitor. So every patient gets this. It depends on the acuity of the patient, on how quickly we're doing this. Because sometimes, they sit in the waiting room forever and we triage them and it may not be an acute presentation, so we may not get all set up. But for these patients, it's important we establish our safety net. So everybody gets IV, O2 monitor. And then here's our warm-up case. So you're treating a 72-year-old male patient, worsening dyspnea over the past 3 days, denies chest pain, has a significant smoking history, hypertension, heart failure, COPD. What else could go wrong with this guy? Occasionally uses home oxygen, vital signs 144/80, heart rate 96, respir's 18, temp 99, SpO2 94 on 2 liters nasal cannula. On exam, rolls at the base bilaterally. You also know myopathy and edema bilaterally. So which labs would be useful in confirming his most likely diagnosis? Just without even going to lecture, what are like the top 2 differentials you're concerned with for this patient? Yeah, CHF and COPD, right? So COPD exacerbations versus CHF. And on here, it could go either way, right? He's got some mild pitting edema. He's already using home oxygen. He's got heart failure. He's got COPD. So what is one test that you guys have probably learned that would be helpful for differentiating, like whether it's CHF or COPD? BMP, right? Yeah, good. So that's going to be, a helpful test when the differential is in question here, or to help confirm or deny our differential on these. But here's our approach to the critical patient. So we'll cover it more like in trauma, but we like to do our, primary assessment. But everybody, we start with airway, breathing, circulation, disability. So for these patients, it is important that we establish that they have an airway, and then we start preparing for the worst if the situation dictates. So for these, a lot of these patients, depending on how extreme that respiratory distress is, a lot of times we'll bring our airway card in and get everything ready for it. And then we want to facilitate that breathing. Everybody gets, they're on the monitor. These patients are all going to get oxygen. Sometimes we have to be careful about oxygen. We'll talk about it more like in our COPD lectures and what sort of oxygen level we like to keep them at. And then we move into circulation, so IV access. We want to make sure we're resuscitating them, supporting that blood pressure. And then we look at their GCS as well, which you guys covered this morning. How did everybody feel about that test this morning?
Good.
Fair?
It's fair.
Anybody got anything they want to get off their chest about it? Anybody? No? Anybody want to argue any questions? I always like to argue. It's fun. All right. So here's our introduction. So what's dyspnea? Really, it's described as a lot of different things, but mainly we describe it as shortness of breath. So it's really like a subjective feeling. They can't breathe, they can't take a deep breath, they have difficulty breathing, something doesn't feel right. A lot of times they say they got like a tightness right here in their chest when they're inhaling or exhaling. And it's usually caused by some sort of pulmonary versus cardiovascular disease, or both. And then we'll talk about all our other types of dyspnea, like dyspnea exertion, orthopnea, all that fun stuff. But here are some other terms we like to use. So tachypnea, rapid breathing. So anything over 20 we consider tachypnea. Then we have like orthopnea, so that's dyspnea in the recumbent position, and is a good indicator of some sort of heart failure or left ventricular failure. We got orthopnea that wakes them up at night, which is paroxysmal nocturnal dyspnea. And usually the patient will describe to you, I was laying down and I had to get up, put a bunch of pillows, or I had to go sit in a chair. I can only sleep in my chair. So there'll be a lot of different, presentations that the patient will describe to you on how they're feeling this. And then what is respiratory distress? So we use this term a lot, but it can be sometimes subjective on our part when we're evaluating that patient. So really, we use the term when that patient has some sort of sensation, a shortness of breath, and then we see signs of some sort of ventilatory or respiratory failure. So they're either not moving enough air in and out of the alveoli, or they're not eliminating that carbon dioxide, which we see commonly in our COPD patients. But it's kind of a broad term, but it does help us hopefully kind of key into what sort of pathology we're dealing with when we see this. But it can be a lot of different things, and we'll show that in the next few slides with our differentials. So it's a pretty wide differential. Here's some pathophysiology for you. So, multiple mechanisms, a lot of it has to do with your central nervous system, and then it creates the patient to have some sort of feeling of shortness of breath. And it causes an imbalance in either their inspiratory drive, sometimes their muscles, sometimes it might be in their lungs and dead space, like in COPD. But here's what we're concerned with. So here's our common cause of dyspnea. The way we like to look at the emergency room is like our differentials of consequence, or our deadly differentials. So what's going to kill the patient the fastest? And that's going to be something related to, obstructing that airway, or like you have on there, like a foreign body. It could be anaphylaxis, angioedema, closing that airway. Or you have like a tension pneumothorax, so that lung is collapsed and it's now causing mediastinal shift, and it's affecting their vital signs or their cardiac output at that point. And then we have other ones, like PE is a big one that we worry about with dyspnea, cardiac tamponade. Then you have other sort of outliers like carbon monoxide poisoning. Hopefully there's some sort of something in the history that can help you identify that. There's probably been a lot of carbon monoxide poisoning this weekend because it was so cold and people bringing heaters inside if they lost power. Neuromuscular weakness is a big one because some of these can be like progressive and it can affect their diaphragm and they can stop breathing. So we always want to consider those neuromuscular weaknesses. And then we have our sepsis, DKA, fat embolism less commonly. And that one's usually associated with some sort of like long bone fracture and pneumonia. But the most common ones are going to be asthma, COPD, heart failure, ischemic heart disease, pneumonia. And it could be psychogenic as well. In the ER, we don't chalk anything up to being psychogenic or psychosomatic until we ruled out every other thing on here. All right, so what do they present with? So tachypnea and tachycardia are going to be like probably your most common presenting signs or clinical features that you would see. And then you might see that accessory muscle use. So you might see that like sternocleidomastoids, or you might see those intercostal muscles. You might see nasal flaring. Inability to speak is a big one. So we always, if a patient's talking to you and they're like, I just woke up this morning and I'm feeling short of breath. So that's very common when we see it, and that's usually a significant sign that something bad is going on with their respiratory system. They can't talk in complete sentences, or they can only get about 3 words out before they move on. And then it can result in like agitation, lethargy, altered mental status, even seizures, depending on what the cause is. You can see that paradoxical abdominal wall movement, which that's a very bad sign. That's usually indicating diaphragmatic fatigue at that point, and we need to do something immediately. May have dusky skin and diaphoresis, but when I was trained, and I still believe it, like history is the most important, probably the most important thing we do in our exam. As long as the patient's able to relate the history to us, it can tell us a lot. Like for most patients, when they present, I get the history from them, and everything else I do is either confirm or refute what my differential diagnosis is to rule it out. But it is important we assess that history in these patients. When we're talking about like airway and vital signs, GCS, are they altered? Can they speak? Are they diaphoretic? Do you see any of those other findings like nasal flaring, inspiratory retractions? And those are common, like inspiratory retractions, nasal flaring, especially in our little pediatric patients, especially our infants. Those are common findings we see because those patients can't describe what they're feeling, and we might see that. And they could have some hypoxemia as well. So once again, IVO2 monitor, so we give them oxygen initially when they present, whether that's 2 liters nasal cannula or we're giving them, 15 liters with a non-rebreather. It just depends on the situation and what the patient can tolerate. If it's a lesser degree of dyspnea, we then like to get a more detailed history, like do they have a history of COPD, do they have a history of asthma? That's going to be important, and kind of change our management directions. Or if they don't, that's might be even more significant. Do I think this maybe is a PE? What other then we start looking at risk factors, which we'll talk about PE in our subsequent lectures. And then some of it could be medication compliance. Right now, it's flu season and it's the winter, so we see a lot of infectious etiologies like pneumonia. We also have a lot of like asthma exacerbations associated with the upper respiratory infections. I mean, I think I see 2 or 3 a shift normally, or I saw 2 on Sunday at least. All right, so dyspnea is also a prominent symptom of heart failure. And like we said at the beginning, we got to differentiate whether we think it's heart failure versus COPD. And they have different treatments, which we'll cover in the subsequent lecture. This one's mainly just for background. All right, so what are we using to diagnose these? So chest x-ray is usually standard in the emergency department for any patient with respiratory distress or presenting with dyspnea. So it's something we need to think about. If the patient's complaining of shortness of breath, you should probably get a chest x-ray on them, would be my recommendation. Or else, it'll come back and bite you. You can also look for like any associations, like is there any JVD? Do they have any like pinion edema that might be associated with heart failure? Do I hear any wheezing? Sometimes in those really bad asthma exacerbations, you can hear it at the door when you walk in your room. So those things can help, but they don't rule in or out any of these causes. You still have to keep a broad differential if you don't know what you're working with first. All right, what do we see on here? Other than a chest x-ray. I know it's not the best image, but
Cardiomegaly.
Definitely cardiomegaly, so that jumps out, right? That's pretty big. And then you see a lot of pulmonary congestion, like the increase signal in all this vasculature here. So there's some sort of pulmonary congestion. This would be a heart failure patient, and what a chest x-ray might look like in this patient. You guys see any like consolidation, like a pneumonia on there? Yes, it's hard to tell, right? So I heard somebody say like maybe right middle lobe. That might be more of that like engorgement of the pulmonary vasculature. And it doesn't say on here. I just like to look at every image. Like maybe, so one thing you see how you got your CPA here. You've got this large heart, but if you follow it down, the trail you see there, or the normal heart silhouette, maybe there's some consolidation there in the left lower lobe. Maybe, I don't know, or I'm just making it up. All right, so following our chest x-ray, a chest CT is a great test in the ER. I don't know if Gendron told you, we scan everybody, man. We call it the donut of truth. We're guilty of scanning a lot of our patients just because it can help us rule out a lot of those deadly differentials that we have. Now, it does expose them to radiation, which is not good, but that's something they can deal with, 20 years from now, not immediately. But great. It's a great test, especially for pulmonary embolism. A CT scan is going to be our test of choice for that. And then you can also, if you have like an equivocal chest x-ray, it can help with the pneumonia, but it's obviously not required. Malignancy, you can certainly find that. Pneumothorax. And then you have like edema, rib fractures, pulmonary contusions. A chest X-ray can see most of that as well, but just not as adequately as you would with a CT. And then some of the labs we get, you know, it depends on the patient. You know, the way I like to look at it for labs is, you know, in training we just kind of shotgun blast everything. Like, I'm going to order a CBC, I'm going to order a CMP, I'm going to order BMP, troponin, which is perfectly fine in a patient with dyspnea in the right setting. But really, every test we order, what I urge you guys to think about is it going to change your management? So if it's not going to change your management, then don't order a test. But for most of these patients, we're going to get EKG, chest X-ray, and normally we get cardiac markers, so we'll get a troponin on there. We usually get a CBC, CMP, and then we decide whether we think it's maybe heart failure, so we might get a BNP on these patients as well. And some of it gets tailored a little bit after that. If they're in like respiratory distress, you know, venous blood gas or an arterial blood gas can be helpful in these patients during their management. And then we also can use point of care ultrasound at the bedside on these patients, which is what we cover in block 5, and we'll teach you guys how to do it. And you'll have a semi-understanding of how to conduct a point of care ultrasound. I'm not saying you're going to be like proficient at it, but you'll at least be a little bit ahead when you get to phase 2, and they're using ultrasound a lot. All right, so here are some more like objective tests we can look at. So we have our pulse oximeter, so that's a quick assessment of what we think their arterial oxygen saturation is. Doesn't tell us gas exchange. Really, it just looks at tissue hypoxia, so like that end tissue, whether it's getting enough oxygen, which is a decent indicator of like their PO2 level or their partial arterial pressure oxygen. We can also get an AVG versus a VBG, and we can compare the two. Usually, if your pulse ox is 90 or above, it's usually a PO2 of 60 or so. So it's a great indicator. We can use end-tidal CO2, which we have a little graph there. Those are our EMEDs, so they're like more, you know, that's like an end-tidal CO2 you can fit in your aid bag. We'll practice a little bit with them during our lab, during our trauma management lab at the end of the semester, and we'll use them on our model, our patient model. But we also, for end-tidal CO2, we also like to look at the graph that's there and the different phases of respiration that we see, our exhalation on there. But it is, you know, it is one of our fastest, you know, indicators of whether it's whether we have ventilatory compromise, which is important. Bedside spirometry. So we don't really use this in the ER. It is something you'll see probably in phase 2. It's great for an outpatient utilization. So the problem with peak expiratory flow rates in the emergency department, you really have to know what their baseline is and test it on a normal patient who's not in distress first, and that's usually not the case when they're in the emergency department. So it's not as helpful for us. If they know their baseline, great, we can get a peak expiratory flow on that patient, but usually in a dyspneic patient, it's very hard to get one on them. We don't use it as often. And then here's our bedside POCUS exam, so we can identify effusions, pneumothorax, tamponade, pulmonary consolidation, volume status, looking at their IVC and collapsibility. I think we got some pictures here. So this one shows B lines, which are like that, which is vertical artifact you see on there. Let me start again. So it looks like a flashlight kind of shining down. The further it goes through the lung fields and the more you have, the higher probability you've got some sort of pulmonary edema in there. So you can kind of see those beams that are coming all the way down. If I can get this to work on here. Yeah, so you kind of see that some of those beams coming all the way down. And that's really just looking at the pleura, and it's reflecting any sort of like fluid in the lymphatics or the interlobula. Let me see, I froze it. All right. So here's what pneumonia would look like. So on the left, we have what we call a static air bronchogram, which is less specific, but it still tells you something's going on. So this would be like a pneumonia versus an atelectasis. Then on the right, we have dynamic air bronchograms, which are pathognomonic for pneumonia. So this is nice and easy. You can do it at the bedside when you're doing your initial evaluation. In a lot of the ERs, we just roll a machine in with us in case we need it, and we'll scan them right at the bedside. And then it'll help give us a better idea whether I think I'm dealing with pneumonia, whether I think there's like a heart failure going on. So it can be helpful for a rapid assessment. We'll still probably get everything else like the chest x-rays and all the ancillary testing, but it can help guide our initial treatment, especially in that acute patient. All right, and then we have our BMP. So this, we use it to identify, a CHF exacerbation. And if it's normal, it typically excludes that acute heart failure exacerbation. The only issue is we can see it elevated with other causes other than heart failure. So you might see it with ischemia, you can see it in PE, sepsis, COPD. Your body's going to release that peptide. And so it could be elevated for other causes as well. But in the right setting, this can help kind of cue us in on whether we think it's heart failure versus COPD versus some other cause like a pneumonia. And then D-dimer testing. So this is for our PE patients. We won't get too in-depth right now on low and moderate pre-test probability. But what it's saying is you have to use a D-dimer in the correct setting. So it's not every patient that comes in with that I suspect a PE. I mean, you could, but if you have a high probability, then you skip your D-dimer. So we only use it in these low and moderate pretest probability cases where we think it may or may not be, and we might have a different diagnosis in question. So it's not as useful for every patient. When I apply it, especially like that moderate pretest probability, I regret it every time, and I just know I should have scanned them, and then I end up scanning them, but I waited an hour. So one of those tests is great in the right setting. So what do we do for these patients? Well, really we need to figure out what that underlying cause of the dyspnea is. In severe dyspnea, we need to make sure that they're adequately oxygenating and ventilating. So we have tools we can use for that. One simple one is just oxygen. Another one is like our non-invasive ventilation or positive pressure ventilation, BiPAP or CPAP are important ones. But our goal is going to be that PO2 over 60, their SpO2 90 or above. Then we need to figure out what's going on with them. Sometimes there's a lot, when a patient feels like they can't take an inspiration or they're not adequately breathing, they get very anxious, which is just worsens the cycles. Sometimes we need to think about treating that as well to provide comfort, especially when they're on those BiPAP machines. Sometimes I've had these respiratory distress cases come in. I think my last one was like a COPD, and we put her on BiPAP, and she just would never improve, and then I ended up sedating her, and that had immediate improvement and everything. So that kind of helped alleviate our problem, was actually treating some of that anxiety that's associated with it. Then we have hypoxia and hypoxemia. Really, hypoxia is just insufficient delivery to tissues. That's what we're measuring on our pulse ox. And hypoxemia is that low PO2, so less than 60. You can have one and not the other. We won't get into details because we kind of rough estimate it unless we're getting a VBG or an ABG on all these patients. But there is a difference between hypoxemia, which is the level in your blood, and then hypoxia, which is the saturation in those tissues. And they're not the same thing. And there can be, other causes of this hypoventilation in these patients. But what do they present with? They'll start to get agitated, headache, somnolence, altered mental status, coma, and seizures. You may or may not see cyanosis. It's not sensitive or specific of hypoxemia, but it is something that might be noted on exam. All right, so like I'd already kind of said, pulse ox kind of predicts what our actual, whether they're hypoxemic or not. So pulse ox over 90 is helpful, but it doesn't exclude hypoxemia unless you get an actual VBG or an ABG or some sort of blood gas. And then you have to also think about like that, carbon monoxide poisoning or other causes that can affect your saturation in your blood. So sometimes it's not the best indicator just using pulse ox, it can overestimate. But we also have special pulse oxes that get carboxyhemoglobin if we suspect it, that we can also utilize. All right, so once again, all that said, we still do the same thing. Give them some oxygen. Make sure they have an airway, and then we titrate it and try to figure out what that underlying cause is, and then we reassess the patient. Are they improving with our oxygen? Do I need to look at non-invasive ventilation like BiPAP, which I think we cover in the next slide? Oh no, we'll go into hypercapnia first. So this is going to be elevated CO2. We have our end tidal meter there, so really we want to keep it between 35 to 45 is what we should normally see their end tidal CO2 at. And this kind of roughly equilibrates to like a PCO2 in that normal range on their blood gas. But we might see this rapid shallow breathing. They might be taking small tidal volumes, underventilating. We see this a lot with our COPD and asthma patients may have some elevated CO2. But like I said, it never results just from increased CO2 production. It's usually some sort of ventilatory compromise that's causing this. And then here are some of the causes of hypercapnia. Most common on there is going to be like our COPD that we see, but we can also have some sort of central nervous system lesion or disease that can cause this. We see it with like overdoses or toxicities. And we also want to think about those kind of rare ones, whether they have, some sort of neuromuscular disease, whether we suspect like a myasthenia gravis or a Guillain-Barré. But most commonly, we'll just see it with, some sort of chronic lung disease in these patients. And then, so there's different mechanisms that cause this depending on what it is, whether it's a central nervous system lesion. We don't need to get into the specifics of it. We just need to make sure in the back of our mind we're keeping some of these other differentials there. But the most common is going to be on the bottom, that hypoventilation due to the dead space for our COPD and those intrinsic lung diseases. And then what signs and symptoms? Basically this almost the same as what you would see if they were hypoxic or hypoxemic. So initially with the acute elevation, you get increased ICP, and then they complain of like a headache, confusion, lethargy, and then the result, seizures, coma, in extreme cases, cardiovascular collapse. In the chronic hypercapnia patients, like our COPDers, you'll see, they'll tolerate, a PCO2 over 80 without any issues. And then, to diagnose it, we can use our end tidal if we have a blood gas that's very helpful. For acute hypercapnia, our bicarb in our blood is an indicator that we have on our blood gas. So we can look at whether it's acute versus chronic depending on the elevation of that bicarb. So we have only small increases if it's acute hypercapnia versus a significant elevation if we're looking at a chronic hypercapnia. So one elevates it like 1 millicu or 1 point really for acute for every 10 of PCO2 rise, or every 10 of their end tidal rise, you might get 1 point increase in their bicarb, and then if it's chronic, you'll have a lot higher of an increase, like 3.5 for every 10. So you can kind of help gauge whether you think it's chronic versus acute hypercapnia. And then here's what our venous blood gas should look like. What do you guys? And you probably don't remember all your metrics, but what difference do you see? Because we're talking about a venous blood gas versus an arterial blood gas on here. Was that? No, not really.
O2 is lower.
Like the big difference is the O2 is going to be different, right? So in a venous blood gas, we're going to have a lower PVO2. So, 36 to 42 is going to be closer to venous, or it's going to be more to a normal, like a 60 we would see on our arterial. So that's the main difference between a venous versus an arterial. So we have to, usually when it's your patient, you know what they're getting, but if you're you know, when you're in phase 2 and you're doing rounds, it's something to think about before you jump to the conclusion, holy cow, they're severely hypoxemic, and you got to think whether it was a venous versus arterial blood gas. And usually in the ER, we jump straight to venous blood gas just because it's a lot easier and more well tolerated versus actually sticking their radial artery. It's a little bit more invasive and a little bit higher risk complication rates.
What's the BE?
What's that?
The BE.
So that's the base excess. It's an acid-base metabolic determinant of how well their body is compensating. So really we're looking at whether there's extra base in the system. So really the higher derangement, whether it's positive or negative, and really it just switches the ions on whether, on how we're reading it, and how much like our hydrogen ions are in the blood, and how well the body's compensating to it. So we'll see it, you know, commonly elevated with like lactic acidosis. We'll see really high base deficits, and that's really an indicator. The higher the number you see, that something is going wrong and the body's not compensating, and we need to do something right now when we see it. But it doesn't tell you exactly anything other than this patient's really sick or, okay, they're compensating appropriately right now. All right, so what do we do for hypercapnia? So this one's not, you know, we can't just give them oxygen to fix this, and that's what makes COPD exacerbations difficult to manage, because we're looking at a ventilatory problem here. So to fix this, we got to increase their respiratory rate, or we have to increase their tidal volume, or both. So that's just, these are the cases we like to use that non-invasive positive pressure ventilation, or BiPAP. So chronic lung disease patients, you know, sometimes we're hesitant using oxygen on them. Really, we give it to everybody. We just keep their oxygen in a little bit different range for those chronic lung disease patients. Like, we keep it between 88 and 92% versus normally like over 94 is what we prefer. And then here's our bi-level positive airway pressure. And this is very common what we use. We basically put a mask on them that looks almost like a mask you use for doing CPR, and it seals around the face. And then we provide inspiratory and expiratory positive pressure to help keep that airway, or those smaller airways, open. And this in turn is going to help, it's going to help their respiratory drive and their comfort level as well. The only issue with it is, you know, the patient has to be mentating appropriately for us to use this. We also have to consider, like, you know, are they PO tolerant? Have they been vomiting? We don't want them vomiting in that mask. But this is an appropriate common tool we use in the emergency department. And we have, like, we start with certain pressures. If anybody asks you, like, what are you going to start them at the BiPAP? Just say 10 over 5. 10 over 5. That's what we start everybody with. All right, so our disposition for hypercapnia depends on what the cause is. So if they have any acidosis, any CNS symptoms, neuromuscular diseases, we're going to keep those patients. If they have COPD and we see any worsening with the respiratory acidosis, we've treated them, given them BiPAP, and if we don't see any improvement, then we'll likely have to admit those patients. But, you know, if the patient's stable, sometimes we can send them home. But I don't know, we talked about it in the first lecture. For, you know, everything in the ER, that we're always looking at whether they're coming or going. So are we admitting this patient, or are we discharging this patient? And that can help drive our management, or not drive our management, that can help us differentiate what we're going to do for the management, whether we think we have to keep them in-house versus not. And the problem with it is we have to call somebody and convince them to take them inpatient. So we usually like to have other appropriate signs on there that we can help tell our consultants that this patient needs to be admitted to the hospital. If only it was easy enough just to call them and say, I want to admit this patient. All right, so here's our little check on learning. 76-year-old woman, history of MI, diabetes, presents shortness of breath. Again, the previous night, waking her twice from sleep. Both occasions she had to sit upright for at least a half hour before being able to lie down again. On exam, you got elevated jugular venous pressure, prominent third heart sound, crackles, bilateral lung exam, and hepatomegaly. Marked swelling and pitted edema bilaterally. Vital signs, heart rate 112, blood pressure 175/85, respiratory 22, SpO2 is 92%, and temp 98.6. What's on our differential for this one?
CHF.
CHF exacerbation, likely we see signs of volume overload with the appropriate history. She's had an MI before. She's having those symptoms at night where it awakens her and she has to sit upright to alleviate those symptoms. With that said, we don't want to stovepipe our diagnosis and kind of anchor on one thing. So we still need to consider other causes. So this patient, maybe she's having an MI, so we want to make sure we're ruling all of that out as well. For this patient, it could be even a pneumonia. Sounds like a CHF exacerbation. We need to rule out ACS or acute coronary syndrome. And then she doesn't have a history of COPD, but it certainly could be COPD as well. So this is when we're going to add all of our ancillary testing on here. All right, what questions you guys got? I know that was kind of quick. Take a 10-minute break, and then we'll go into asthma, allergy, and what we're going to be talking about. So more of the disorders. So we'll start with acute asthma, very common, especially certain times of year, depending on asthma exacerbations. And then there's good old Tim Nolly. Here's what we're going to talk about. So we'll define it, talk a little bit about pathophys, basically same exact thing we do for every lecture. Talk about the treatment and then the disposition of these patients. So here's our warm-up case. You got a 16-year-old female, presents to the ER for dyspnea and wheezing, history of asthma, tried albuterol inhaler at home a few times without relief, vital signs, blood pressure 116 over 68, heart rate 100. Respir's 24, temp 98, SpO2 92% on room air. This is like your classic asthma patient you see on every shift. I think I saw 2 last Sunday when I was working. We see them all the time, especially during like flu seasons, allergy seasons, or anything else that would cause an exacerbation. So we'll talk about and we'll dive into the treatments for these, but it's pretty simple. We use 4 mainstays of therapy, and then we assess their response. We hopefully never have to intubate these patients. It never goes well. Normally when we provide a breathing tube in most of our other patients, we can actually affect their oxygenation and ventilation, but for asthma, we haven't really fixed any of the underlying disorder, which is going to be all that inflammation in their lungs, which we'll talk about in the pathophysiology. So when would we need to consider intubation? Hopefully never, but we'll talk about some of the cases where we might. But that's all, every provider's goal is do everything we can to avoid intubating these patients. All right, so here's our, same approach, A, B, C, D. So for these ones, we need to make sure they have an appropriate airway. A lot of times you can hear their wheezing from the doorway in these patients. We start all of them, we have our 4 mainstays of therapy, which are oxygen, and then some sort of SABA or short activated agonist like albuterol, ipratropium, or an anticholinergic. We have a medication that mixes those together called a EMED, so you'll commonly hear us say that. And then we want to get those patients on steroids. So those are the 4 mainstays of our treatment for these asthmatic patients. And then we can look at MAG and EPI in those status asthmaticus patients or the severe ones, which we'll cover here further in the lecture. All right, so asthma, this is a chronic inflammatory disorder of the lungs. They'll have their air, all of their airways, and their small airways are going to have a hyper responsiveness to any sort of stimuli that can cause these infections or asthma exacerbations. And the reason I say, it can be all sorts of different things, from medications to environmental triggers to upper respiratory infection. I think most commonly we see an upper respiratory infection with it. But the inflammation causes, those episodes of wheezing, breathlessness, chest tightness. They'll be tachypnic, and they'll usually have a cough with this. It's worse at night, or especially when they're laying down. The one way we categorize it is these are all typically reversible. So it depends on how long or the duration of it. And then what our treatment is initially and whether we can reverse this or not. So there it is. Most attacks are reversible. They'll improve spontaneously with treatment, and sometimes it can be extremely quick. We give 1 Duaneb and you'll see immediate improvement. And then the steroids start to take effect a few hours later to help calm more of that inflammation down. And this is the ideal patient that we can typically reverse it. with minimal treatment. You know, the ones we worry about are those status asthmaticus patients, but this is very common. 8% of the population has some sort of disease. And most of them we discharge home. So the majority get to go home. Yes, it can be fatal, and those are the ones we're always watching out for. But, you know, what we see in it is for the pathophysiology, so you have all of those inflammatory cells, and they accumulate in those smaller airways. So you'll have, you know, first off, the inflammation causes a reduction in that airway diameter. And then all that inflammation can affect smooth muscle contraction, bronchial wall edema. You'll get thick secretions in those airways, and all of this can compromise their ventilation. And then, like I kind of talked about, triggers, so like likely multifactorial. Common ones we see are some sort of upper respiratory infection or environmental triggers, like during the season changes in the year. Some people can have an exposure to cold air and they get an asthma exacerbation, stress. You have some of your like anti-inflammatories can cause an asthma exacerbation, like aspirin and NSAIDs, and then you also have beta blockers as well that can trigger an asthma exacerbation. Then you also have exercise-induced asthma as well. You guys will see more than your share of those patients, especially like in the Army when you're working at a battalion aid station. Everybody who fails an ACFT will think they have asthma, and you're like, you probably don't have asthma. But something common you will see. All right, so what are the clinical features? So shortness of breath is going to be a big one. They're going to show up wheezing, and usually they'll have a cough associated with it. Hopefully we can relay the history of asthma on presentation from the patient. They normally tell you, yeah, I have a history of asthma. And then they'll complain like, you know, that tightness in their chest or constriction. And then they'll become wheezy. One of the issues is expiration become prolonged. You see accessory muscle use, so we always want to assess whether we see those accessory muscles, nasal flaring, we see their sternocleidomastoid muscle while they're breathing. This can help us identify, you know, that acute exacerbation and how severe we think it is. Other things can have wheezing too. So if only stuff was that easy in medicine, like, yep, wheezing, it's asthma. We also want to consider like our heart failure, PE, did they swallow something, especially in our young kiddos. We want to keep in the back of our mind, like they don't have a history of asthma and this presented like extremely acutely, then you need to think maybe they swallowed something. So that's something we always consider in those little kiddos that we might have concern for asthma. It could be anaphylaxis, and then pneumonia can also present with wheezing as well. So history is extremely important in these patients. Obviously, if they have a history of asthma, and then you want to look at what might have triggered this. Did you have a recent, you know, upper respiratory infection? They'll say they had a runny nose, cough, congestion, fever. And that can help you kind of guide what caused it. Sometimes if you know the trigger, like certain times of year, the patients will tell you, yep, I did an exacerbation every time spring hits and the pollen comes out. Or what do we have here, the cedar or whatever. So you'll see that a lot here. And then you want to know from the history, like what's important is with their previous exacerbation. So we always want to get that in the history. So one of the questions I always like to ask, have you ever been hospitalized for this? And you should ask all your asthma patients. And then you want to ask them, have you ever required a breathing tube? And that should increase your suspicion of how bad this is going to be or where it might go if we don't do something about this right now. So, you know, most patients will have had a hospitalization or two. Fewer patients will have had breathing tubes. But if you hear that, it should increase your pucker factor if they say they've been they've been intubated or needed a breathing tube. I had like a 38-year-old a while ago. It's like morbidly obese, like 400 pounds. He had CHF already. Just horrible. But I asked him, I was like, you ever been hospitalized? He's like, yeah. I was like, how many times? He's like, I don't know. I was like, you ever needed a breathing tube? He's like, yeah. I was like, how many? He's like, 13. And immediately I was like, oh shit, grab the airway card, get everything ready. When you know, this could go downhill real quick. And that's when we jump to all our other medications for status asthmaticus right at the beginning, which we'll talk about here. But here's like our asthma severity classification, which I think you guys covered in POEM. We don't really, this really doesn't affect our treatment in the ER. We're assessing the patient. Really, the patient usually doesn't know what type of asthma, whether it's, you know, intermittent, whether they have mild, moderate, severe. But here are some of like what their pulmonary expiratory flow might look like, or their FEV1. No, you don't need to know those numbers on there, so don't Don't try to go through there and memorize them. This just kind of tells you the severity of the exacerbation and what treatments we use. So we use the same for in everybody: oxygen, nebulizer, steroids. And then we look at whether we have to add any adjunctive therapy like our magnesium or epinephrine on top of that. All right. So physical exam, same on everybody. Get our ABCs, vital signs, what's their level of consciousness, how quickly are they breathing, are they able to complete sentences during your exam? That's always important, of how dyspneic they are. And then sometimes the mild ones only have that cough and maybe wheezing at the bases of their lungs, and they're not very acute. Like it says, you can a lot of times hear wheezing at the doorway for those severe cases. And then once again, always think about those other conditions. Then we want to look at their use of accessory muscles to try to assess their air movement and whether we think they're fatiguing out. So depending on how long this exacerbation has been going on for, their body can only tolerate so much of it. So we want to assess that when we're evaluating these patients and kind of make a decision on whether I think this is going to go south quickly versus discharge that patient home. So, like it says, paradoxical respiration is like when you see the belly going, when you see that distinction between the belly and the chest when they're breathing. So that's like a very significant sign of impending ventilatory failure. So we always want to look out for that. And then any alteration in mental status is a significant finding, because that usually means that they're tiring out. So we need to do something about that right now if we see that initially. But most of the time, you'll hear wheezing, sometimes in all your lung fields, sometimes just at the bases, and then you might not hear great, like when you're assessing their respiratory status on whether they're able to take the breath, an inspiration and expiration appropriately, and so we judge that. And then the silent chest is usually like at that last, that's that last sign. And sometimes you might think they improved. So most of these patients are going to be like tachypnic. If they're about to have that silent chest, they'll usually have started tiring out. So they'll be tachypnic in like the 30s, and they're tolerating it. And all of a sudden, if you see them improve immediately, that's usually portends like a poor outcome, like they've got some sort of severe obstruction, and they're not able to move air appropriately. But those are all things we're looking for in these asthmatic patients. All right, and then here's some of our mimickers. So heart failure can have wheezing, any airway obstruction, pneumonias, PE, vocal cord dysfunction, tumors. These are all considerations we take into account when we're evaluating these patients. So, what do we use for our diagnostic testing? Really, we don't need a ton for these. So most of the time we're just getting that pulse ox on that patient, and we're kind of assessing whether they're appropriately oxygenating those tissues. And we can use a rough estimation from there. We don't use the FEV1 or the peak expiratory flow in the emergency department, but that is part of the diagnostic criteria when you're talking about asthma, just not for these acute exacerbations. And then we can get a blood gas, but usually they're not needed in most exacerbations because they're not severe. You guys think we need chest x-ray in every one of these? What do you think? Get chest x-ray in all asthma patients? No? No, yeah, we normally don't need a chest x-ray in these patients. Unless we're concerned with like an underlying pneumonia. I got a guy last weekend he had like 7 days of URI type symptoms, and then he had like 3 days of an asthma exacerbation. So that patient, I got a chest x-ray in just because with how long that URI's been going on, I was worried about maybe it could be a pneumonia on top of this mild exacerbation. So those are the few times I would. We don't need a CBC in all these patients. Well, I mean, we don't need a CBC in most patients, but a lot of times, people will order a CBC, but not for asthma. If we're worried about an infection, a CBC might be helpful to help us identify some sort of underlying infection or illness in these patients, but it really doesn't change our management. Once again, we don't need an EKG on all these patients. Now, like for that guy I was talking about who had heart failure and exacerbation, that's something I would consider getting EKG and ruling out any sort of cardiac pathology as well. But normally if we get one, we're going to see, usually it's going to be tachycardic, we might see right ventricular strain, and then just non-specific T-wave and ST findings on those EKGs. All right, so here's what our standard is and what you guys need to know. So our first line therapy for all these patients, like I said, it's these 4 mainstays of therapy. So that's going to be our oxygen. It's going to be a short-acting beta agonist like albuterol, and then an anticholinergic like ipratropium. We mix them together. We call it a duoneb, or it comes pre-mixed, I should say. And we call it a duoneb. And so we place a nebulizer on these patients. They say they take like 20 minutes or so for a nebulizer to run. That nebulizer is hooked to the wall oxygen. And we need to get steroids on board early in these patients to help with that inflammation. So steroids don't work immediately. I mean, IV and PO have similar like pharmacokinetics and how soon you can get that into the bloodstream and system. It's usually like 4 to 6 hours later you'll start to see those steroids taking effect with that exacerbation. But most of our asthmatics can be treated with this. And then the only change we see with as long as they're not severe and in status asthmatic is, it just depends on how many rounds of that duoneb we can give. So for duoneb, we can give 3 rounds, and that's usually over the first hour. So every 20 minutes we give a duoneb treatment. After that, we use just albuterol because we don't want to give them too many anticholinergics and dry them up. They can have side effects with it. So sometimes we can give what we call a continuous nebulizer, where we dump 15 milligrams of albuterol in there, and they just breathe it for the next hour or so. But the goal is we need to rapidly reverse it right now. And if we can do that initially, and depending on how the duration of how long this has been, they've been symptomatic, then we can usually fix it pretty quick. This is complicated, you don't need to know it. Some people, I guess, learn or like to learn from this. It's in there. This is like a common algorithm. You'll see an up-to-date on how we manage these patients and what we do for our asthma exacerbation. And really it just kind of identified, so it starts with peak expiratory flow, which we normally don't get. Then it goes into moderate versus severe, whether we got a good response or response incomplete, and whether we need to admit that patient or discharge them home. So bottom line from this. So here are the severe asthmatic patients, just like with the status epi. Basically, we've provided our treatment. They're still having symptoms. It's refractory to treatment. So if we don't see any improvement with our usual doses, and that's typically over an hour when we give those 3 duonebs and possibly albuterol, we reassess and they're still hypoxemic, they're tachypnic, tachycardic, you see those respiratory muscle usage, then we need to think about a status asthmaticus, so they're not responding to our normal therapy and reversing that airway obstruction. So this is when we move into some of our other adjuncts, like our BiPAP or non-invasive ventilation, which most of these we're doing together at the same time. So we're throwing up, we don't see a response initially, they're still worsening. We'll place them on BiPAP to see if we can improve their respiratory drive. And a lot of times that just helps keep those airways open for the patient to breathe appropriately. You'll see a lot more comfort with it when we place that on there. We add magnesium sulfate on there in the management. We don't know exactly what everything magnesium does in the body, but it's related to almost all of your, biochemical processes. So it does have great effect in asthma. And then we can add epinephrine as well as standard treatment. If they're if we think it's an anaphylactic type of asthma. So sometimes we overlook the epi, but it can be helpful to give them an IM injection at epi, or we can do push dose epi as well. If we're going to intubate, ketamine is a great sedation agent for any sort of respiratory underlying lung diseases. So we prefer that because it has bronchodilator properties in it. So a lot of times we'll give, if we're going to look at intubating, we'll give a dose of ketamine, or we'll use ketamine as our induction agent for it, and it works great. All right. So here's something you'll see in the status asthmaticus patients. So if they have that progressive hypercarbia, so you see and if you have end-tidal CO2, you'll start to see it rise. If you have a blood gas, you'll see that increase in PCO2. Like I said at the beginning, if we intubate them and start mechanical ventilation, we haven't relieved that underlying obstruction. So that's why that's why this is our last resort, is intubating these patients. And it can be helpful in those severe cases, but if we do intubate them, we like to allow permissive hypercapnia, so sometimes we'll adjust our respiratory rate and tidal volumes on these patients so that they can better tolerate the intubation. All right, so here's some other, these aren't currently in the guidelines, but some people use these or they might talk about them. The only one I would say that is starting to come into standard practice, there's some long-acting beta agonists and studies during exacerbations that are showing promise. It's still not the standard of care yet, but everything else is not something that's going to be acutely helpful for an asthma exacerbation. But some you may or may not see them starting antibiotics on these patients, or some of those leukotriene antagonists. All right, so what are we doing at the end of the day for these patients? Are they coming or going? So really, if we see a great response to treatment for these patients, we might not see complete resolution of the wheezing, but you see improvement. You see improvement in their O2 saturation, their tachypnea is improving. A lot of times we can send these patients home. We always want to consider whether we think they can be compliant, whether they live by themselves at home. We also want to look at some of those social factors as well for these patients on whether they can tolerate our treatment if we send them out of here. A lot of times it's going to be younger pediatric patients, and the parents are usually up to speed on the treatment, so we can send them home. If we do, we want to make sure they have that short-acting beta agonist, so rescue inhaler. We want to make sure they have nebulizer treatments at home and a nebulizer machine. And then everybody we discharge needs to go home on steroids for these asthma exacerbations. All right, so here are the ones we're sending home. Good response to treatment, symptoms relatively resolved, and then we don't really worry about their peak expiratory flow or FEV1. They're the ones we admit, there's no response, so we've given them all those rounds of albuterol, they're still tachypnic, still hypoxic. Those are ones we're going to keep in the hospital. And then anybody who continues to have those persistent symptoms, still wheezing, still short of breath, we haven't seen improvement, we may put those into the category of coming into the hospital versus going home. We may not improve every symptom, but as long as we're seeing objective improvement on our exam, then we can likely send them home. And here's what we're sending them home with. So it's important everybody, has those inhaled medications like the short-acting beta agonist. They have a nebulizer. Sometimes we have to teach them how to use it if it's their first exacerbation. We tell them to do 2 to 6 puffs, every 4 hours, for usually the next 72 hours until their exacerbation is improved. We also make sure they have nebulizer treatment as well, so sometimes we have to prescribe that when they go home. Usually we give them some sort of high-dose steroids to go home with, so usually 50 to 60 milligrams of prednisone. Most commonly we like to use dexamethasone. It has a better profile for the lungs and asthma exacerbations. So typically we'll give an IM injection when they're in the immediately when they present, when we give our DUANEB treatment, and then we can send them with another dose home because it's a longer, dexamethasone is a longer acting steroid. Hopefully they have a peak flow meter. That's something they can follow up with their PCM with. Then we want to make sure they have an actual PCM and follow up. They can be managed with this. So these are what we need to do for all our patients going home. A lot of them will have an asthma action plan as well, especially those kiddos they require for school and everything. All right, so here's our disposition. If they fail to improve, we're admitting them. Most of them can go home. And then intubated patients always go to the ICU. when we're admitting them. Hopefully it never, hopefully it doesn't come to that with these patients. What questions y'all got? And that was a lot. What's up?
The permissive hypercapnia, what's like a range that you would? Like,
So I don't think it's really a range. It's
Okay.
more of like a tolerability, but really a stability of the patient. So if we don't like to chase lab parameters, so sometimes you would think with an elevated CO2 we need to lower that. But for those ones, we'll let it ride a little bit more, like into the 50s when we're treating those patients. But yeah, there's not like an actual range that we're targeting. What else? Nothing? You guys ready to go home? Anybody's pipes burst? No, sorry. All right. I'll stick around if anybody has any questions. That's all I got for today.